So again, we've been hearing how total ankle is really the gold standard now. Good outcomes, especially in fixed bearing, compared to ankle fusion, high patient satisfaction rates. But again, as was seen in the literature, you can have pretty good short-term outcomes, but as you drag it out longer, midterm, long-term, they don't do as well. And total ankles historically were known to have a much higher risk of revisions and complications. So there are a lot of challenges to doing total ankle replacement. It's very technically demanding surgery, but certainly challenges in terms of the anatomy of the ankle, implant designs, patient comorbidities, complications of the surgery, and also technical error. So obviously at a basic level anatomy, I mean, the ankle is very different than the hip or the knee, the shoulder. So limited exposures, everything's very close, limited soft tissue envelope, especially as patients that are post-traumatic, small bones, abnormal shape of bones. The strength of the bone is very weak once you've gone through that subchondral plate. Designs that had very thin polys that didn't really compensate for enough, range of motion that's multifactorial, very high forces going through the joint, small surface areas that lead to increased stresses. So the design goals, I think, have modified a little bit. For the most part, it's been the same. Everything's listed here, trying to correct the deformity, limit the bone resection, get good fixation, in whatever way you can do that, maintain range of motion. But there are going to be complications. And so our Canadian colleagues came up with this system in terms of grade and the amount of grade that might lead to failure. And we've seen that this study showed that 1 in 4 of total ankles are associated with some type of complication, and over 35% can be high grade, so lead to implant failure. So that's pretty significant. And eventually we know all of them are going to fail at some point.